But the histology by itself is not able to predict malignant transformation. And I wanted to share this study with you. It's from the Kaiser Permanente system. They have excellent reporting and an excellent network of data. And they looked at 4,800 patients retrospectively, all of whom had leukoplaskia, and a subset of those went on to develop squamous cell carcinoma. And in that cohort, 39.6% of squamous cell carcinomas arose from a previous lesion, a previously biopsied lesion that had no dysplasia. So these are those reports we get back that say hyperkeratosis or even no dysplasia or mild dysplasia would fit into categories like this. Sometimes we see some uncertainty in the diagnosis, some uncertainty in the biopsy report. And so just like this example where we have a white patch on the tongue, this was a reassuring biopsy, but ultimately that developed into squamous cell carcinoma because as the surgeon, even in a head and neck practice, we're not quite sure which ones need treatment and which ones don't.
So looking at what's beyond the histology, right? This has been around for decades as far as genetics goes, as far as evaluation of molecular pathways goes. This, is just a short cohort of the things that people have looked at. We've looked at LOH and loss of heterozygosity. We've looked at different cytokeratin expressions, depending on weight. We've looked at vascular endothelial growth factors, inflammatory responses, COX-2 pathways, different stromal reactive pathways that we've looked at for years. And I really love using this diagram. I use it a lot of times in my kind of outside lectures on oral cancer. And this was written, the subcaption for this was simplified diagrammatic view of major molecular events that talk about progression to cancer. Well, we all know this is actually not linear. So when I present this, I usually talk about it's not usually a linear pathway. There's a lot of variables here in regards to where the biopsy was done, at what point in time the biopsy was done. There's not always this linear transformation from normal to hyperplasia to hyperkeratosis, dysplasia, and cancer. We can have cases that are mild or show no overt evidence of dysplastic change that can become invasive squamous cell carcinoma within a matter of months. I've seen that in our practice. The question always comes up, well, are there variables? Well, there are variables. Maybe they didn't biopsy the right site. But this is something that is a real world problem. And these are the different pathways that we have looked at in regards to transformation from an oral potentially malignant disorder to invasive disease. So it is a complex thing. And like Tony had mentioned, this is one of those things where S100A7 has stood out. And I've had the ability for the little over 2 years now to evaluate all the cases that are coming in through the United States. And because I'm a huge nerd, some of the ones that are coming in through Canada, right? And I have been able to find some patterns in a lot of what we're seeing. S100A7, largely published, and I think Tony kind of alluded to some of these publications. But the big point about some of this is that you're going to have cohorts of individuals that on histology are going to show a low grade of dysplasia or mild or moderate grade of dysplasia, or even non-dysplastic that are going to have these genetic changes that now we can exploit. We have the ability to exploit these changes. So good pathologists can use this as an adjunct tool, or clinicians can use this as an adjunct tool to help figure out where this thing is going instead of giving this gray sort of nebulous range of transformation that we're giving to our patients nowadays.
Now, our STRATICYTE test is based on a protein biomarker that's been extensively studied, and it has been shown to help cancer cells invade and migrate and metastasize. And so it stands to reason that before a precancerous lesion becomes malignant, that it will overexpress this protein. Now, here you can tell on the left, this is a normal H&E slide viewed by the pathologist, but here we see abundant overexpression of S100. This platform does a tremendous job because it was based on 811 biomarkers, and S100A7 outperformed all of them. So looking at a huge number of biomarkers and picking the best performing one was a great strategy to develop this test. And so here's an example of how it works in real time. There's a special stain applied, and then a scanner looks at all of the epithelium. Normally, a pathologist looks with the microscope and scans all the epithelium, and then looks at the area where it looks the most concerning. This is all digitized, and so the volume of each individual cell is measured, and then a region of interest is identified with the greatest expression and the greatest abnormality in cell size. And based on a database of 150 cases with known clinical outcomes, all patients who had precancer, some of whom developed into cancer, this test can compare these findings with those patients, and that's actually where the patent is. That's where the secret is, which is being able to predict based on these findings which patients will develop cancer. So you as the clinician get a score back. You get your 5-year risk of probability, 5-year probability of progression to cancer, and you get to now tell your patient your risk is X, not I don't really know the range. It's anywhere from 1 to 40%. We're not sure what to do. You get to confidently look at that patient and say, we have a risk, and now we're going to decide for behavior modification, increased follow-ups, laser treatment, excision, or whatever it may be. What I've seen in this is it's actually a practice builder. Patients come expecting this kind of conversation, and very educated people I have found seek us out because they want this dynamic. Our chair emeritus of the Department of Surgery, excellent surgeon, not always a huge supporter of OMS in his time here, but he brought his wife specifically for this test for me to offer. So we see increasing credibility, and it really helps, I think, to reestablish that trust between the patient and doctor, when in the past we've always had that bit of ambiguity and that uncertainty in managing dysplasia. So lots of data that we can make available to John after the call. We've got, any of you who are interested in the papers and all the data behind this, but suffice to say, all of these are changes happening at the pre-microscopic level. So even if the pathologist sees dysplasia, we're not really looking at that with the STRATICYTE test. We're looking at the molecular changes behind the scenes that can't be detected. And so this is kind of the standard we're all used to, the way we were all trained. We have a patient who has a suspicious lesion seen by the dentist. They're sent to us for a biopsy. We send that to histopath, and we get results back with ambiguity. But now the same exact process is followed. We don't have any new biopsy that's required. Your exact same procedure can be performed, and that tissue is sent to your pathologist, and then that same tissue can also be sent to for STRATICYTE testing. And Dr. Paris Patel, who's next, will talk a little bit more about the specifics of that as the lab director in Dallas. So now you get this report back. You've still done everything the same for the patient, still received that referral from the dentist, you've still done the biopsy, but now you get histopath. You'll still get your same biopsy report you always have, but now you get this additional piece of information that really in my practice has been revolutionary. I mean, it's really changed the conversation and the management for patients. It also has informed follow-up. When patients in the past were told they had mild or moderate dysplasia, they didn't always come back. We'd lose them to follow-up. Life gets in the way, and they wouldn't come back and see us. Now they'll come back and say, well, I know I have a 30% risk, and I need to be followed. And so it really helps with patient compliance too.